This
and
conference
future
will now be
sessions.
recorded.
So, again, welcome to everyone that decided to participate here this evening. We certainly appreciate you guys taking time out of your busy schedules to be here. We wanted to bring you up to speed a little bit on what kind of AMNP is doing or has been doing over the past several months. Obviously, as I mentioned earlier, things have changed, and you guys are very well aware of that. I wanted to talk a little bit about our legislative advocacy efforts. That's one of the big things that your association does on your behalf. So we are actively engaged and consistently lobbying for improved practice for you guys here in the state of Missouri. And we've had a number of different bills out there that we've advocated. There were 12 specific bills this year that dealt directly with APRNs. House Bill 1816, which was basically to remove the geographic proximity barrier. Senate Bill 714 was to create a license for APRNs. Senate Bill 942 was one that we were able to defeat because that had some pretty harmful language in it that would have made the routine procedures that you guys are doing in the office. You guys wouldn't have been able to do those if that bill would have been passed as filed. In addition to that, it basically said that even if you had earned a doctorate degree, that you wouldn't be able to use that, and it would have held you liable for some false advertising that you may not have had control over. So we were able to successfully defeat that. Senate Bill 965 is the Access Improvement for Missourians bill. That was a very comprehensive bill that we sought to pass, and unfortunately we ran out of time, and the legislature took a 6-week break right in the middle of session that nobody anticipated. That's the first time that's ever happened that I'm aware of. So we'll bring that back next year and hopefully get some progress on that. Senate Bill 1078 also dealt specifically with APRNs and basically wanted to put APRNs under the control of the Board of Healing Arts rather than the Board of Nursing. So we were able to get to defeat that as well, and that's kind of where things stand. So that was kind of a part of our legislative advocacy efforts. For those of you that are members, you're getting those updates on a regular basis, on a weekly basis during session. They are out of regular session now. They are in a special session to deal with some crime bills that Governor Parson called them back in for. There is a rumor that we're going to have a special session that will deal with liability for COVID situation, and that would include liability protections for healthcare providers. So we'll certainly keep you up to speed on that. That hasn't been officially called yet, but when it is, we'll certainly keep you in the loop on that. One of the biggest things that we were active with when the legislature was not in session because of COVID was we were actively advocating for suspension of rules. And so those of you that are members of ours have probably seen some of the summaries that we sent out relative to the rule suspensions. We were able to get a suspension on the geographic proximity rule, on the 30-day preceptor rule, on the chart review rule. We were able to get it to where APRNs could order home health services, as well as be the attending physician, if you will, in hospice care. So there was five or six different suspensions that we were able to successfully secure from the governor's office. We worked alongside our colleagues at the Missouri Nurses Association as well as the CRNA Association to try to get those suspensions passed. Those were suspended until May, and then they were extended until July, and then we were finally able to get them pushed back all the way through the end of the year. So all of those suspensions are active until December 30th. We were also very active in our COVID response. We were doing our best to disseminate information that was being sent out. We coordinated some webinars to kind of keep our members up to speed with an infectious disease NP expert, and we have been coordinating some surveys as well to give folks, policymakers and others, some insight into what's happening with NPs related to the COVID response. So those are some of the things that we were doing. Some of the things we've got coming up. We have our annual conference. You guys have probably seen emails on those. Our annual conference is coming up October 9th and 10th. That's going to be at the Lake of the Ozarks. I know a lot of you guys are probably itching for some time out, some time away. That's a great opportunity for that. We will take all precautions and adhere to the CDC guidelines on that. If you'd rather not participate in that in person, which we would certainly encourage you to participate in person, but we understand if you're not able to do that. We are offering a virtual option as well. So if you'd like to attend the conference but can't do so at the Lake of the Ozarks, feel free to get signed up, and we'll stream it to you virtually, and or you can have access to that, throughout the 90 days post-conference. We are looking at also offering an advanced diagnostics course here next month. That's going to be completely virtual. So we're going to Dr. Shannon Chapman, Dr. Chris Hemmer, Miranda Vincent, I believe her last name is going to present on advanced diagnostics. So EKGs, labs, radiology, CT, MRIs, those sorts of things will be discussed in that 8-hour course. Again, that's going to be offered virtually, and that's going to be held on September 12th. If you can't attend on September 12th,
Why don't you plug it in somewhere or use it or whatever?
if you're not able to attend that day, you can still access that course after that's over with. We are in the process of trying to put together a virtual job fair. I'm not sure how soon that's going to come to fruition, but we are looking at that and hoping to connect some of those that may have been displaced due to COVID. Try to provide some recruiting and some job opportunities. So we're going to be doing that. That'll be open to our members. We're also exploring additional CE opportunities virtually for those that are looking for that. And then we are also trying to do some preceptor connections with our student members, connecting those with seasoned NPs that are willing to kind of take them under their wing and be their preceptors. So those are just some of the things that AMNP is doing on behalf of our members, and we certainly appreciate those of you that are members. If you're not yet a member, we would certainly encourage you to get signed up. We have student rates, retiree rates, and then regular member rates, working NP rates, very reasonable, and that membership helps sustain the organization and helps us do what we're doing here. So with that, I'm going to turn it over to Dr. Mecklin. Dr. Mecklin, are you on now? Let me see here. It might take us just a second.
Yes, Derek. Let me thank you.
Yeah, we got him. So I'm going to make you the presenter here, Dr. Mecklin. And I apologize, I don't have your bio here in front of me. So I'll let you introduce yourself. And there we go. You got it.
All right, let me just pull this up here. Okay. All right, thanks, Derek. So my name is Dr. Clayton Mecklin. I'm a urologist here in Columbia, Missouri. I specialize in men's health and erectile dysfunction and some male reconstructive surgery that goes along with that. As far as my education, I went to St. Louis University for medical school and graduate school. And then I went out to Albany, New York, where I did my urology residency, general surgery internship, and I did a year of fellowship in male infertility, sexual health, and reconstructive surgery. Then I came back here about 8 years ago and joined the practice, and I've been here since. And this is definitely something that I am very interested in and feel passionate about. So thank you all for giving me the time to speak to you. We're going to keep this relatively informal. I'll add a few things along the way and make sure you guys ask questions or send a text or use the chat icon so that we know what to talk about at the end and answer the questions. So moving along here, this is a very common condition. 30 million men in the US suffer from erectile dysfunction, so it's very common. 1 in 2 men by the time they get to be 40 years of age will have some erectile dysfunction. And we like to think that it's not an inevitable part of aging. It is more common as you get older, but shouldn't be expected or just generally accepted. And in most cases, we're able to treat it and overcome the problem. So it's important to recognize diseases associated with erectile dysfunction. And this is important. One of my mentors used the analogy of canary in the coal mine. A lot of times erectile dysfunction is the first symptom that a guy has, and this is a guy on no medications, otherwise healthy, but it can be the first symptom that there's another major medical problem that's going on and not being addressed. And if we look at this chart, it shows the different causes of erectile dysfunction. We see a small percentage are going to be endocrine. That would be low testosterone, pituitary adenoma, things like that. 5% are neurological, so this could be a spinal cord injury or some other neurologic cause. 6% are going to be those due to surgery or radiation or trauma of the pelvis. So for urologists, that would be radical prostatectomy, taking out the prostate for prostate cancer, or radiation for prostate cancer. People that have had pelvic trauma in a car accident, things like that. 15% medications. And then we see a huge percentage are going to be diabetes and vascular, 70% combined. And I'm sure that's something that you guys treat a lot and see a lot of. When you look at the most frequent reasons for office visits to a primary physician in middle-aged men, so 45 to 64, we've got diabetes, a general screening exam, lipid disorders, and hypertension. And those are very, diabetes, hypertension, and lipid disorders are very strongly associated with erectile dysfunction. Probably the three things, conditions that I see where we actually diagnose a medical problem, not just treat the ED, are guys with high cholesterol, low testosterone, or diabetes. So whenever I see a guy that comes in with ED, especially a young guy, otherwise healthy, he's got significant erectile dysfunction, I'm going to check a hemoglobin A1C, total testosterone, and his cholesterol. Because every once in a while you get a young guy and you'll check his lipids and it's over, triglycerides over 400. He's got a genetic disorder and didn't even know it. So it's always important to work him up and make sure there's no other medical problems going on. 80% of these are going to be due to a physical problem. So and this is important because if you get a young guy, 20, 30 years old, don't just assume it's in his head and it's psychological, because there could very well be an anatomic reason for the problem. We see 65% of men with vascular disease have erectile dysfunction, and then 53% of men with diabetes have difficulty with the erections, and that number is going to go way up the older an individual gets. So men with diabetes also tend to have much worse erectile dysfunction and failed treatments at a much younger age because of their diabetes. So looking at the stigma of erectile dysfunction, and this is something we see when we try and have a seminar and get people to show up. They don't want to show up in public because they're embarrassed about this condition and they don't want to bring it up to their doctors, and that's what this study showed. So if we look at our graph here on the left, we see 3 out of 4 guys were too embarrassed to bring it up with their primary doc, no matter how bad it was. Some of them, about 1 in 4, said, hey, I think it's just part of aging. I'm not going to bother asking my doc about it. 9% unaware. They didn't know that their doc could even treat this. 5% thought it was unworthy of their doctor's time and didn't want to discuss it. We see that 82% of guys actually want their primary care doc to ask them or bring it up, as opposed to them asking their doc. And then we talked about those that were too embarrassed. And only about 22% actually asked their primary provider about their erectile dysfunction, if there was anything that could be done. So why should you care? We know you guys are all busy. You're treating major problems like coronary artery disease, diabetes, all these other things. Why should we ask about the erections? Well, if untreated, we know that it can lead to depression, emasculation, a fall in self-confidence, anxiety. I mean, especially a younger guy with severe erectile dysfunction that's single, can't really date. It's a very awkward situation. It can really, cause people to withdraw and associated with major mental health problems. Obviously, it can impact relationships. and sometimes guys will just kind of blame their partner for other things when really they just need this erectile dysfunction or this problem addressed. And then we mentioned that it's a possible indicator for other disease states like coronary vascular disease and diabetes. And so there are multiple studies that have shown that erectile dysfunction many times will appear 3 to 5 years before any symptoms of cardiovascular disease like coronary artery disease. It's always important to check those other things out too. So what can you do as a primary provider? Well, the big thing is to initiate the conversation, and this can be a little awkward. So I recommend just starting with, do you have any problems with, especially in somebody that's high risk, like someone with diabetes, coronary vascular disease, somebody that's had stents in their heart, you know, those guys are going to be high risk. Ask them, do you have any problems with intimacy? That's pretty easy way to start. And then they say, yes, well, what about the erections? Any difficulty maintaining those erections? And they may say, yeah, well, you know, maybe a little bit. And then you start to ask them more about it. And are they satisfactory for intercourse and reliable? And if they say no, then you can go on to work them up. There are some questionnaires to use. Sometimes guys are still a little bit embarrassed to fill those out, but they can be really helpful because you know, one, if a guy's really motivated, he's going to fill it out and circle that he has a problem. And then you also know that if a guy doesn't have a problem, you don't have to even go there. You don't have to bring it up. If he circles, you know, zeros and everything, then you just move on to the next topic. And that's the example shown on the right is a SHIM score that we commonly use to assess for erectile dysfunction. So good news, there are lots of treatment options. Some of those are non-surgical, such as medications, and then surgical options. So what are some non-surgical treatment options? We always want to use a shared decision-making model. So we like to try and involve the partner with the discussion if possible. We're going to identify the treatments based on their values and priorities. Some people may say, I don't mind using a vacuum erection device. We've been married for 30 years. It's just not a big deal. We're not embarrassed. Whereas other guys might say, I want to have spontaneity. I'm dating. I don't want to have to go and do an injection 15 minutes before I want to have, you know, relations with somebody. And so if we look down here at the bottom of the screen, we see some of the options. Lifestyle changes. Obviously, when you're screening for those medical problems, you gotta assess for that. Multiple studies have shown stopping smoking, cardiovascular exercise, fixing your lipid disorders, is all treating high blood pressure can all help sexual function. You're going to look at your medications. Are you on any medications such as some hypertensive medications may be associated with erectile dysfunction? And then we also have medications that we use for erectile dysfunction, and you all are probably familiar with those. Those are going to be your PDE5 inhibitors. We have 2 generic ones on the market now, Viagra and Cialis. And there are some other ones, Levitra and very short-acting medications like Stindra. Those tend to be pretty expensive. All these have similar side effects. They can lower blood pressure, cause headache, nasal stuffiness. Rarely Viagra cause some blurry vision, or some of these can cause low back pain. So you always want to counsel the patients about that. You also want to tell them, a lot of times guys just get the medications, but they're not really told how to use them. For example, Viagra, you want to take it on an empty stomach, you know, an hour before intercourse. So if you take it with dinner and you have this 4-course meal, it's gonna, absorption is gonna be delayed. So it's not gonna, you're gonna be asleep. It's gonna hit your system, you know, at midnight, and you're not gonna get the benefits. So you gotta use them right. And it's important to tell people how they're supposed to use these when they take them. There are medications that you actually put inside the opening of the urethra. Those can either be a pellet that looks like a little baby aspirin, or a gel that you squirt in there. It's absorbed into the penis, dilates the blood vessels, acts locally, so you don't have some of those systemic side effects. About 1 in 3 guys will have some pain in the urethra with that, but it is an option. Vacuum erection device, obviously you don't have any side effects like the medication. It works by negative pressure, drawing blood into the penis. And then you have to put a ring at the base of the penis to try and trap the blood in. That can have some side effects. Sometimes the penis is kind of floppy. Sometimes you can get numb or cold, which obviously takes away the satisfaction. But for some individuals, it works and it's fine. It's another option. Penile injections, basically another way to get the medication into the penis. You inject the medication in there. Some people have a little pain or bruising at the site. You can use these on blood thinners. So guys that aren't great surgical candidates may want to use the injection therapy. The big risk of this is going to be a prolonged erection or priapism. So an erection lasting longer than 4 hours, then it is an emergency, and they have to go to the back to their urologist or to the emergency room to get try and get that reversed. And sometimes that even needs a procedure. So that's the main risk with that. And the erections don't go down after you climax or orgasm. You have to wait for the medication to wear off. So what are some surgical options? This is something that I specialize in. So the penile implant. It sounds kind of scary to a lot of guys or complicated at first, but it's really not. Basically, instead of the two tubes, the corpora, that normally fill up with blood to give you an erection, we put an inflatable cylinder in there. And that's full of saline, salt water, the same solution as all the cells in your body, so it wouldn't hurt you if anything leaked out. There's a little pump down in the sac or the scrotum, and then a reservoir underneath the abdominal wall behind the pubic bone. So everything's inside you. You could be naked in a locker room after you're all healed up. Nobody's going to know it's in there. You can go through the airport, metal detector, it's not going to show up. You can have MRIs with these without a problem. It is a one-way street, so once you put the implant in, you don't take it out and go back to a less invasive treatment. But it is a permanent solution, so you're going to have spontaneity. You're going to get an erection whenever you want for as long as you want it, and it will go down when you're done. There's a little release valve that lets out the fluid. This is an outpatient procedure, so it's all done through about a 1 to 1.5 inch incision above the base of the penis. There's a little drain we often leave in after plastic surgery that we take out a few days later. 98% patient satisfaction and upper 90s partner satisfaction as well. So very, very high satisfaction rate for the procedure. It doesn't affect sensation or urination. It is a mechanical or device, so there's always a small risk of part malfunction. I usually quote people around 10% over their lifetime having to go in and replace a part. It is a foreign body, just like if we replaced your knee or your hip, so there's always a small risk of infection. We always make sure diabetes is under good control. I like to see hemoglobin A1C is in that 7 range or less when we operate and do this procedure. If it does get infected, we would take it out, put another one back in. That's very rare, 1 to 2%. And I'd probably less than that in a non-diabetic, low-risk patient. Usually I tell people about 2 weeks, taking it easy, no heavy lifting, strenuous exercise. If you have a desk job, that second week you may be able to go back to work on lighter duty. No really heavy lifting for that first 4 weeks, but most guys are back to their regular activity after 2 weeks of the surgery. So how can we ensure patients get the care that they deserve? Well, we want to initiate the conversation. The first thing is just ask. Make sure you ask. Treat the patient when appropriate. Start them on those PDE5 inhibitors if they need to. Check their testosterone, associated medical conditions, and when they fail, go on to the next step. And that's the big thing. Is a lot of these guys have failed or been on PDE5 inhibitors and given 2 or 3 different PDE5 inhibitors over 2 or 3 years, and nothing's worked. And so they've delayed treatment. You're going to know. I usually say you want to try it about 6 to 8 times. Try the medication, max it out. If you're not getting any response, then go to the next step. Don't just keep throwing money and time at the problem. We gotta move on. And that involves making that follow-up appointment with a specialist that deals with those more advanced treatments. And then when they see the specialist, obviously we're going to do a full comprehensive evaluation and discuss those things that I discussed tonight. And it's really important, especially when you're discussing surgery, to see a specialist that does a lot of these. Just like if you want your hip replaced, you don't want a guy that does 3 hip replacements a year. You want a guy that does them 2 or 3 times a week, or 2 or 3 in a day. So you really want to find somebody with high volume when you do these procedures to minimize the risk of any complications. Let me just go on here and then take this time to answer any questions, and just anything you guys want to ask, go ahead. I think Derek will let me know if there's some things that were texted or on the chat.
Yeah, it doesn't look like there was anything submitted via chat function yet, but everybody's been muted. If you have a specific question for Dr. Mecklin that you'd like to ask, don't be bashful. You can unmute your microphone just using the controls there on your screen to ask the question, or you're welcome to type that question in to the chat function as well. So we'll just kind of open it up for questions, unless you had anything else that you wanted to cover before the Q&A, Dr. Mecklin?
No, I think that's fine. Go ahead and open it up.
Dr.
Okay.
Mecklin,
Yes.
can I ask a question kind of related to this? You mentioned prostate issues. We follow the United States Preventive Task Force guidelines, but what are you seeing or what you're recommending for the prostate testing to rule out?
Yeah, so for PSA testing, we do, there's a little bit of a discrepancy between some of our guidelines and in those. I mean, we
Yes.
do recommend a screening, and that depends on your risk stratification. So we look at, do you have an immediate family member, African Americans are at higher risk, and really you want to we recommend getting a single test early on. So certainly those high risk guys, a lot of times will get a test at 40 to 45, and definitely by 50, we recommend everybody get a PSA test. And then it depends really what that number is, because there are multiple studies showing that if that number is very, very low, under 50, we don't have to do it every year. You could get one at 40, and you could wait, if you're very low risk, several years before checking it again. We also have some other things like 4K scores that give us a little bit more information. And there's some studies showing that if that 4K score is very, very low, you can be a little bit more relaxed on that. But I think one thing that people don't always understand is that, it's important to do the rectal exam. It's important to check that PSA. Some real high risk cancers may not have a high PSA, but they may have an abnormal rectal exam. So we recommend doing both of those things in individuals, and kind of depends on your risk there, but in terms of when you start. But it certainly doesn't hurt to get a PSA at 40, just to see where you're starting at and go from there.
Okay, thank you.
Yeah.
Well, questions that came in via text says insurance coverage for outpatient surgery.
Yeah, so it is outpatient surgery. Everybody goes home the same day, unless they don't have a ride, which sometimes happens because they have a general anesthetic for the procedure. Medicare does cover the surgery. Most private insurers cover it, but there are some that don't. We always check ahead of time. We have some programs set up with cash discounts and worked out with the hospital and things for individual if it's not covered. But fortunately, usually it is.
Okay, next question. Can you talk about how you check testosterone, at what levels you consider replacing, and what route of medication you choose?
Yeah, so that testosterone is a big topic. And, as urologists, we see a lot of guys that really never even met the indications for replacement, and gone to shot boxes and men's health centers and things, and getting real high doses of testosterone. So we use both the AUA and the Endocrine Society guidelines. And so one of those uses 300, one of those uses 350. It's important to get 2 tests showing that it's low. I'm not a big stickler on which one you use, certainly 300. It's important that you have symptoms, so you don't really ever treat in isolation. The rare example, I mean, without symptoms, the rare example might be somebody that's young that is super low, that may be at some health conditions or at higher risk for bone loss and other things, diabetes down the road. So those are the general cutoffs. We do know that guys with testosterones in the low 200s and certainly lower than 200 are going to be at higher risk for problems down the road, such as osteoporosis, increased insulin resistance with their diabetes, and erectile dysfunction. Once it drops down there to the 100s, usually you lose nighttime erections and you have some pretty significant symptoms. So that's really it. I mean, we see you're going to see a lot of guys that were getting it and their testosterone was 900, and they never feel good. They always need more. So it's really important when you start to start at the right level. I like testosterone pellets because you only need them 2-3 times a year. It's a simple office procedure with a little local. We can kind of control the levels. There's no way you can abuse the testosterone because, I mean, the doc puts it in. And it's uncommon to see polycythemia and some of the other side effects with that. But, you know, we have a lot of people that do injections because it's cheap, and that's what the insurance company pays for. We don't see a lot of guys doing topicals just because it's pretty variable. Compliance is low. They got to do it every day. The levels are up and down. If they miss a day, they're going to bottom out. So most of our guys are going to be shots or the pellets. Now, the one thing I say is very, very important about testosterone, because I deal with a lot of guys with male infertility. We see so many guys that did not know that being on testosterone can make you sterile. They've been doing injections and they're young, in their 20s, for a couple of years, and they have 0 sperm. So if you have a guy that is planning on having children, they have to know that testosterone replacement therapy can impact fertility. So that's always an important thing, and sometimes that slips through the cracks when these guys see they go to a men's health clinic, or sometimes even the primary provider. So.
Okay, next question says, when you say low T, do you mean total T or free T?
Yeah, so that's, you know, for screening, we start with a total T. Because, I mean, if your total T is 500, it's fine. I mean, the free T doesn't even matter, you know. But some people have used bioavailable or free testosterone to try and see, you know, how, say you're on the border, you're like 350, you know, should I replace them, should I not? Should I use, you know, a bioavailable, which is actually the most accurate, but that's kind of complicated. You've got to check 3 or 4 different things. Sex binding globulin, free testosterone total, and the lab calculates it. And, you know, really, I mean, that's, if a guy has a testosterone 300 and you believe he is symptomatic, then you can do a trial of testosterone. You know, you don't have to make it too difficult. I mean, it's I think if they qualify, they qualify, and that, as urologist and from our AUA, that's what we go by. I think it may be a little more complicated with the Endocrine Society, but in terms of whether they use that or not. But I mean, for all practical purposes, can't go wrong using that total testosterone and looking to see if they have symptoms, as long as you use a reasonable cutoff.
Okay, next question here says, are the injection or urethral inserted medication indicated for patients who can't take oral meds, i.e. on nitrates?
Yeah, I mean, they could definitely qualify for those. We have guys that do that because they can't take them. You just have to be careful because a lot of times we'll do a Doppler ultrasound with injection testing in the office, and we kind of know how much they're going to need. Because if you have a guy that responds very well to Cialis or Viagra, but just can't take them, you give him an injection, he's going to have a higher risk of priapism or prolonged erection because his blood flow is not that bad. Same thing with a guy with a nerve injury with normal blood flow. So you just have to be really careful with counseling them as to the risk of priapism and starting with a really low dose if that's the case.
Okay, thanks for that. Next question, at what percentage of an increase in the PSA do you find suspicious enough to stop the pellet insertion, or do you do the DR and if negative, continue with the pellet injection?
Yeah, so that's a little trickier. You know, some people will bounce up and down, and I, you know, certainly if you're at 4, I mean, if you meet the cutoff, you're on testosterone replacement therapy. I would stop it and then refer them, you know, for further evaluation. There are some age cutoffs, like if you're 50, well, you don't have to do 4. Your PSA should be much lower. Certainly, if it doubles, I usually kind of use 6-month cycles because that's usually how often we see people. So, you know, if your PSA is going up significantly and doubling, then we need to evaluate it. Sometimes we'll do a 4K score to stratify them further. But you have to be careful because if you just stop it, remember, one of our treatments for prostate cancer is to block your testosterone. So especially if a guy's been on it for a while and makes no testosterone himself, his testicles are shut down, then if you stop it, it's like castrating him. So his PSA may go down, but it doesn't mean he doesn't have cancer. If you restart it, it'll go right back up. So it's important not to just stop it, but to figure out what's going on and rule out any potential prostate cancer. And then at that point, I would just refer to a urologist.
Okay. Any additional questions? Does anybody want to ask a question live rather than via chat? If you'd like to do that, you're welcome to do that. Just unmute your microphone to ask those questions. Doesn't look, oh, here comes another one. What is the difference between ED and anorgasmia? Will PDE5s help with that?
Sure. Yeah, so a lot of times we see guys and they kind of mix up, you know, what's really going on. So erectile dysfunction is just the inability to get and keep an erection. So just the hard erection. Doesn't have anything to do with climaxing or orgasm or ejaculation. So Cialis will help with the erectile dysfunction, but not necessarily anorgasmia. Now, that's a little tricky because maybe they don't orgasm because they can't keep the erection long enough to have satisfactory intercourse or climax. So you kind of have to tease it out. And if you think at all that there might be something going on here with the erections, then maybe worth a trial of that to see if it helps. But you also have to think about, you know, if they don't have difficulty getting the erections, they just can't climax. You got to look at, you know, medications. So SSRIs, antidepressants, can prevent you from climaxing or ejaculating. We actually use those medications sometimes for premature ejaculation. So it's important to differentiate the two, but you know, sometimes there's a little bit of both going on.
Okay, thank you. Any additional questions? There is a slide that Walter had sent that I'll send out to all the folks who attended this. that was referencing, I believe, your SHIM score, or I'm not sure if I'm saying that right. So I'll email that out to everyone that attended. Any last thoughts there, Dr. Mecklin?
No. Thanks to everybody for attending, and don't be shy. You can always give us a call or call the office or leave a message if you have a question. You want to give me a ring, or want to send a patient to be evaluated, or just more information. Just let me know. We'll help in any way we can.
Okay, we appreciate your time.
Okay, thank you.
We've still got some giveaways that we need to do here. Oh, hang on just a second. Looks like, just a couple of comments here. It says, thank you very much and thanks a lot.
Okay, thank you.
Thank you, appreciate it. Okay, give me just a second here. We'll get back to the agenda. So thanks to Walter and Dr. Mecklin for sponsoring this virtual meet and greet. Very informative. Right now, we just kind of want to take an opportunity to kind of connect the NPs that are on the call. So are there any NPs on the call that are currently, or any students that are currently looking for preceptors?
This is Debbie Blinsler, and I have a third semester Cox College student with me this semester, and she's looking for someone to do OB with also.
Okay. All right. Can you email me? You should have my email address. Can you email me her contact information, what she's looking for, and we'll make sure that we get that out?
Yes, I will.
Thank you. Anybody else looking for a preceptor?
Hi, my name is Becca, and I'm a nurse practitioner and have been for well over 12 years, but I took a sabbatical and I haven't worked in a couple of years, and every time I apply, they're telling me I need current experience or precepting. I'm looking for a nurse practitioner that I can shadow in maybe like CVS, pharmacy, urgent care kind of thing.
Yeah, if you'll email me, that would be great, and we'll collect all of this. Looks like Kirsten Hancock, I see your comment there. You'll need a preceptor for clinical starting in spring 2020, and Demetri Jenkins is looking as well. If you guys can email me your contact information and exactly what you're looking for, we'll make sure that we get you connected to the right folks. So.
And can you just give us that email address?
Sure. Yeah, you're welcome to send that to nursepractitioners@missouriNP.org. So you can just reply back to the email that I sent earlier with the login information for this.
Okay.
Is there anyone? You're welcome. Is there anyone that's looking for job opportunities on the line now?
Yes, I have to speak up again. I'm sorry. Actually, I was kind of looking for the NP that worked at Cox Bariatric because I saw an announcement for an opening there, and I was interested in that and looking for a position.
Okay. Becca, it's showing your name as Jack S. So I'm not sure.
Well, that would be the name of my computer. So,
Oh, okay.
Sorry, my real name is Rebecca Matthews.
Okay.
And that's how I'm registered for the event.
Okay. Perfect. Thank you. All right. Looks like Callie Ballinger is looking for a preceptor for AMNP and educational leadership starting in January. So if you guys will just email me that your contact information, what you're looking for, we'll get that out. Again, anybody looking for job opportunities? All right. Let me do something here real quick. So it looks like Walter and Dr. Mecklin left. That's we're going to use them to start our prize giveaway. You too, Debbie, because I'm getting some feedback on your line there. Hang on just a sec. Nope. Now we got it. Okay, good. So Julie, are you on?
Yep, I'm here.
Okay. For those of you that don't know, Julie Long is the president of the Association of Missouri Nurse Practitioners. We've also just recently held our board election, and those folks will be, the new board members will be seated in January. So you'll be seeing some information come out about those new board members that are going to represent you guys in your statewide association. If you need their contact information or would like to connect with them, feel free to reach out, and I'm happy to connect you with those folks as well. Also, if you'd like to get involved in committees, whether it's the advocacy committee for the legislative issues or membership or our education, continuing education or networking, we are always welcoming new folks to the mix. Doesn't matter if you're a student, if you're a retiree, if you're a full-time NP, whatever the case may be, we would certainly welcome you guys to help out. And we appreciate those that currently do contribute in some way, shape, or form. So, Julie, if you would give me a number between 1 and 31, that's the first person that we will select for our door prizes. So we have 6 door prizes in total. We'll have 4 $25 Amazon gift cards, and then we'll have a couple of Real Heroes Wear Scrubs t-shirts that we'll give away. So, Julie, you want to give me a number between 1 and 31?
Oh, how about 18?
18. Christy Kreutzer. I probably butchered your last name. Are you on?
I am on, yes.
All right. If you will send me your email address, I will send you a Amazon gift card.
Perfect.
And if you'll give me a number between 1 and 31 that's not 18.
How about 23?
23. Rebecca Matthews was just on. Rebecca, you still there?
I am. I'm still here. Wow.
All right.
Thanks.
You're,
Awesome.
you win a $25 Amazon gift card. So if you'll do the same thing, email me with your email address. I probably have it, but just to be certain, I'm sending it to the right one. If you'll email me your contact info, I'll get you the gift card. And then also, I need you to pick a number between 1 and 31.
Me? Oh, okay. 5.
Deborah Blensler,
Thank you.
you win the 3rd Amazon gift card.
Great. Appreciate that.
And if you'll give me a number between 1 and 31, please.
How about 5?
That's you.
Oh, okay. How about 12?
12. Patty Garcia. Patty, are you on? Patty was on earlier. She got on late, but I know that she was on.
Yes, I'm here.
Oh, gotcha. All right.
Yeah.
Patty, do you shop on Amazon?
Do I what?
Do you shop on Amazon?
Well, doesn't everybody?
That's what I was going to say. Yeah, probably so. All right. I've got your email address because I know I just sent that to you. So I'll send that to you. If you'll give me
Okay.
number 131 for a t-shirt.
Who, me?
Patty, yeah,
Oh,
Patty, give me a number.
16.
16, Dimitri Jenkins. Dimitri, are you still on?
Oh, yes, I'm here. Thank you.
All right, perfect. Can you send me your shirt size, and we'll get you a t-shirt sent out. A Real Heroes
Wonderful.
Wear Scrubs.
Say that again, sorry.
We'll send you the Real Heroes Wear Scrubs t-shirt.
Thank you so much. Awesome.
Sure. And if you'll just give me one last number here, we'll give our final prize away there, and then
Okay.
if there's any
How
additional
about
comments.
27.
27. Suzanne Opperman, are you on?
Yes, I am.
All right, same thing. If you'll email me your shirt size, we will make sure
Cool.
that we'll get you guys a t-shirt. And those, I believe, they're running low on quantity, but I know that they're still out there. So if anybody else wants one of those Real Heroes Wear Scrub t-shirt, you can always go on the AMNP Facebook page and go back a little bit, and we link to that. You can order yourself one on there. So, well, with that, we appreciate everybody again taking time out of their day to attend. And again, if you're not an AMNP member, we would certainly welcome your membership, and we appreciate all of those that are. And if there's ever anything that we can do for you or be a resource for you, we're more than happy to help and be a resource for you in whether it's questions that you might have about the law or your practice, or if we're able to connect you in some way, shape, or form to who you're looking for, we'd love to help you out. So with that, we're going to go ahead and say good night. Again, thanks to all that participated, and we hope to see you on one in the future. And if you haven't yet signed up for the conference, we'd encourage you to. So thanks, guys.
When is the program going to come out about the conference?
There was a couple of speakers that canceled due to the COVID situation, so they're trying to finalize that. So I suspect that it's probably going to be in the next week or so, hopefully.
Okay. All righty. I'll keep my eye out for it. Thank
Okay,
you.
sounds good. Thanks so much, guys.
Bye.
Have a good night.